Do you hear us well?
Yes, I hear you very well. Thank you.
Oh, perfect. Yep.
So first of all, I do apologize for not attending this meeting in person, but last time, for personal reasons, I had to stay in Marseille.
We understand and we appreciate that it's not easy times for you. So we really appreciate that you can take like some minutes for us and for the audience, the families and the scientists here. So we really appreciate it and we thank you so much. Merci beaucoup.
Merci. So first, I'm going to present myself. I'm a senior scientist working in basic science in Marseille at INMED. This is here. This is the Institute of Neurobiology of Mediterranean. And I lead a team working on perinatal imprinting and neurodevelopmental disease. So for nearly almost 30 years, I worked on mouse models of Prader-Willi syndrome. And we were the first to identify the MAGEL2 gene in 1999 in human and mouse genomes. And we identified this gene as a new candidate gene for Prader-Willi syndrome. And later on, Christian Schaaf showed that mutations in this MAGEL2 gene lead to Schaaf-Yang syndrome. So MAGEL2, as I said, is involved in rare disease, in Prader-Willi syndrome and in Schaaf-Yang syndrome, and both syndromes share many symptoms, including early feeding problems, developmental delay, intellectual disability, breathing defects, hypogonadism, hypotonia, ASD, and even obesity that appears later on in Schaaf-Yang syndrome. What is important to say is that in the situation of Prader-Willi syndrome, there is a large deletion on chromosome 15q11q13, including several genes, and MAGEL2 is one of these genes that is deleted. So there is no expression at all of MAGEL2. In the case of Schaaf-Yang syndrome, only point mutations appear in the MAGEL2 gene. So it means that all the other genes are present. They do work correctly, but this gene only is mutated, and point mutation give rise to a truncated protein. So this is a scheme drawn by Tim Schubert and Christian Schaaf, and it does summarize the pathophysiology of Schaaf-Yang syndrome. And you can see that there are different symptoms. And what is important is that all the symptoms can be the cause of a dysfunction of brain mainly, even if it's a peripheral symptom. So brain is complex and is a complex electrical network. It's made of 96 billion of neurons and many other cell types that are very important for neuronal function. Neurons communicate between them via electrical signals, and those signals are transmitted via the synapse. And there are 600,000 billions of synapses in the brain. You have an incredible network of connection between the different neurons, and this is a real image. And all those connections and the electrical network enable the organization of a complex electrical network far more powerful than any computer, and this is the function of the brain. So importantly, we can note that a baby brain is not an adult brain, a small adult brain, okay? So it's not a brain that is going to grow up to become adult. It's a brain, it's a different brain under construction that functions at least in part differently. And the network is built up until adulthood, and it takes 20 years, at least in human, and 60 days in mouse. And we know the different steps that allow just neurulation, proliferation of cells, neurogenesis, migration, and so on, that are necessary to build a brain. Those different steps and mechanisms are similar in human and mouse. So why to use mouse or rat models? There is a high genetic similarity between rat, mouse, and human. Mice share about 85% of their genes with human. In mouse, we can control genetic manipulation, and we can create genetic mouse models in which we can create mutations of the different mouse genes to inactivate them, for instance, as in human disease. It's quite important to understand the pathophysiology with longitudinal study. As I said, a mouse is adult at 60 days, so it means that we can study from conception nearly to birth until adulthood, and in holding mice as well. And we can test new therapies. Transgenic mice serve as reliable platform for testing new drugs, gene therapies, or other intervention before moving to human clinical trials. We can perform behavioral studies. Neurological disease often led to changes in behavior, cognition, motor function, and so on. And transgenic mice can be tested in those assays to study how genetic changes affect their aspect of brain function and how therapeutical treatment can rescue a normal behavior. We can compare studies between control mice or even with other pathological models with our mouse model. And we can access, as I said, to the complexity of brain. Finally, we can, because mice are in an animal facility, so we can use a lot of mouse, and this is important to have large cohorts of mice in the same environment to be able to have sound and solid results. So about the MAGEL2 in my team, we have identified the gene, as I said, in 1999, and after that we have created a MAGEL2 knockout mouse model. Knockout means that it's a deficient. How does it work? Here is a wild-type mouse, and in each cell you have the genome, and you have the MAGEL2 gene. What we can do, that those lead to a protein. This is the protein is the result of the coding gene, and this is the protein. That is the molecule that is going just to play a role in the cell and in the organism. We can inactivate by genetic tools these genes, and at the end we have no expression of the gene and no protein. So it's a loss of function of MAGEL2 in all cells of the mouse. But Schaaf-Yang syndrome is due to a loss of function of the normal protein. This protein does not exist anymore in all cells of the patients. But instead, we have the presence of a truncated protein. It's why it's point mutation that give rise to a truncated protein. A truncated protein means that the protein is shorter, and it's different from the normal protein, and it can play a role that is different from the normal protein. So it's really caused by the lack of the normal protein, and the gain of function of an abnormal protein. There is no mouse model with a truncated protein, but it does exist a rat model, and Christian Schaaf's team works on this rat model now. So what we have done with our mouse model, in which MAGEL2 is inactivated, so there is no protein associated, is that first we observe that 50% of the pups die between P0 means the day of birth, and P1 it means that it's 1 day after birth. So they die the first day of life, and they die because there is a feeding deficiency. You can see here this is the milk in the stomach. In the MAGEL2 mouse model, there is no milk in the stomach, and it means that we have shown that this feeding deficiency is due to the lack of good sucking activity. And this is what has been observed in Schaaf-Yang syndrome babies as in Prader-Willi babies. So we have a sucking deficit in MAGEL2 deficient born. Of course, I mean, they are not fed, so they die. This is not the case of patients because they are fed by tube feeding. So the question is, what does occur just to prevent this sucking activity? There is hypotonia, but what does prevent that? So just to say that birth is really very high traumatic event in the life, and maybe the most traumatic event in the life because the baby is in utero and with passive nutrient uptake, with passive breathing, with any function of the thermoregulation, cardiovascular system, and but suddenly after birth. The baby has to air breathe. He has to have a good function of the cardiovascular system, metabolic regulation, thermoregulation, renal adaptation, and an active enteral feeding. So the baby has to feed. So what caused that? To be honest, there are few studies in this period because it's difficult to work at this period of time. But we know that there is a surge of hormones. Just like cortisol, different kind of hormones. And because MAGEL2 is highly expressed in hypothalamus, so hypothalamus is a brain region that encodes for the different hormones that are going to be released partly in the blood and in the brain. And so we measure the quantity of hormone at birth in our mouse model, and we observe that there is a high reduction of the production of oxytocin, vasopressin, orexin, and other hormones. So many hormones are produced by, the hypothalamus, and the oxytocin is produced by hypothalamus as well. And what do we know about oxytocin? So oxytocin is a small molecule, and it produced here in the brain. It's going to be released in the blood, or it's going to act in the brain at different places of the brain. So what is a hormone? A hormone is a small molecule that is in the blood or in the circulation, and that is going to act on the cell via a receptor. Okay, the receptor is just a key, and a key is going just to enter the cell via the receptor. Like that, it can play a role at different levels. And we know that oxytocin is really important, for instance, for parturition, for lactation. Without oxytocin, a mother cannot produce milk. And it has also many other functions at the peripheral level, meaning at the different level of the organs. And it does play a role, we say central role, because it plays a role in the brain as well, and it's an important role just to control social behavior, to control anxiety, to control depression, and so on. And oxytocin, as I said before, a baby brain is not an adult brain, it's a different brain that is going to be constructed to give rise to an adult brain. And what we know is that oxytocin is released from birth, not before. And the quantity of oxytocin varies at the different ages of one individual between birth and adulthood. And oxytocin receptors that are absolutely necessary just to allow the action of oxytocin. So those receptors are present at the cell membrane. They're going to give rise a signal of oxytocin and give a signal to the cell. And the cell is going just to trigger a behavior, to trigger an electrical signal, for instance, neurons. And those receptors, the level of expression of those receptors varies between the different ages. So it's really a dynamic system. So what we showed, to make a long story, to make short, we decided to administrate oxytocin to MAGEL2 pups just after birth, and to see what we can to observe the consequences of this administration. And we observed that the administration of oxytocin, it was 2 micrograms subcutaneously, just subcutaneously, is just under the epidermis, under the skin, is enough to rescue a normal sucking behavior of the pups. And so this was not shown before, and we to really show that oxytocin is necessary for the sucking initiation. What we performed is so we used a molecule that is going to prevent the action of oxytocin. The name is antagonist of oxytocin receptors. And when we we stop the action of oxytocin just after birth in wild-type pups, we observe that half of the pups die because they are not able to feed properly to suck. So it does mean that oxytocin is really important for the initiation of the sucking activity and later on for sucking. So this is summarized here. In MAGEL2 knockout pup, there is no sucking activity. The administration subcutaneously of oxytocin is able just to trigger sucking. And so it means that MAGEL2 as a molecule is going just to interfere with the oxytocin system to allow suckling. So this can be explained because MAGEL2 is highly expressed in neurons that produce oxytocin and in the different brain regions that express the oxytocin receptors. And in MAGEL2 knockout pups, we observe an abnormal release of oxytocin. So we went further in the study of the behavior of MAGEL2 pups when they survive, because I said half of them survive. And we observed from birth to adulthood different alterations in the behavior, and we observed mainly social alteration, an increase of some behaviors, just like grooming, rearing in females, that are considered in mouse just like autistic behavior. Grooming is just a normal behavior in mouse. Except that if they groom too much, it means that it's an abnormal behavior. We performed many tests and to look at the social behavior of these mice. How do they interact between another mouse? And we showed social alterations. And we also show that there is a problem of cognition, and for that we use the Maurice Watermaze test. So I'm not going to explain to you all the different tests we are able just to do in mice to be able to assess those different behaviors, but they are quite well recognized and very sound and solid to allow us to conclude that there is really a problem of kind of autistic behavior. I'm just going to explain you what is, for instance, Maurice Watermaze. It's a test to assess cognition. It's one of the most widely used tasks in behavioral neuroscience for studying cognition and learning and memory. And the basic test is very simple. So here you have a swimming pool, and in the room you have different visual cues, and the mouse, and in the swimming pool, so the water is not transparent, and there is a hidden platform. So you have to know that mice don't like water, and they don't like swimming. It's different from rats like swimming. And so if you put a mouse in this water, the mouse is going to swim until the time she's going to find the hidden platform, and she is going to stay on the hidden platform. And so the first day is going to take some time, and the last day, 3 days later, the mouse, because of the visual cues in the room, is going just to locate quite properly the platform, and she is going just to go directly to the hidden platform. So what we measure is the time to for the mouse just to go directly to the hidden platform. It means that the mouse is able just to recognize the visual cues and is able just to learn where is the hidden platform. And this doesn't work, for instance, in different neurological pathologies, and in the case of the mouse model in which MAGEL2 is inactivated. So what we did, again, is just to treat the pups the first day of life with oxytocin, and we administered at this time 1 dose of oxytocin every day during the first week of life. And we assess the different behaviors, performing the same test, just to test ultrasonic vocalization. This is a way to communicate between the mother and the pup. So the pup is going to emit ultrasonic vocalization, and this is the first social relationship with the mother. And we observed that with this kind of treatment, we could rescue nearly all the abnormal behaviors we observed previously. So it means that there is an action of oxytocin administered the first week of life at adulthood. It's a long-term action of oxytocin. So this is important because we also performed at adulthood, for instance, an administration of oxytocin. It's an acute administration of oxytocin. And when we do that, and we try just to do here is a social test, but we can do the Maurice Watermaid test as well. We observe that just after the administration, at least 1 hour after, we can rescue a normal behavior. But 3 days after that, we lost this rescue. So it means that there is a transient effect with an acute administration of oxytocin at adulthood. But, as I said, an oxytocin treatment during the first week of life has a real long-term effect. So, what is the effect of an early oxytocin treatment in MAGEL2 knockout mice at the level of the brain and of the cells? So I'm not going to enter into details. We show that the administration of oxytocin normalizes the release of oxytocin in neonates and later on at adulthood, normalizes what we call the kind of excitatory inhibition balance in the brain of the MAGEL2 knockout mice. So just to say a brief word, it means that, in the brain you have an electrical activity, so you have some excitation, you have some inhibition in the different pathway, in the different connection, and there is kind of balance between excitation and inhibition. And this balance was lost in MAGEL2 knockout mice. We were able to normalize other anatomical and functional brain alterations, so these are just don't care about that. And we normalize also the expression of oxytocin receptors at adulthood because the expression of those receptors were disturbed in MAGEL2 knockout. So it means that the action of oxytocin administered during the first week of life has real effect on at the cellular level in the brain, and has real effect on the brain function. And we can rescue at least normalized many of the brain alteration by the administration of oxytocin in early life. So this is the conclusion of what we observed in the mice. We were able to restore sucking activity after the administration of oxytocin just in neonates. Positive effect on social behavior and cognition. So it means that oxytocin treatment has long-term effects, normalizes nearly all the alteration observed in the MAGEL2 deficient mice. So we propose at this time that oxytocin administration in principle might be the best treatment at this time to improve sucking and later on cognition and social behavior in Prader-Willi syndrome, potentially in Schaaf-Yang syndrome, and possibly in other neurodevelopmental diseases. So in Prader-Willi syndrome, in collaboration with Maïté Taubert in France, who is at the head of the reference center of Prader-Willi syndrome, we performed this test. So she decided just to administrate oxytocin in Prader-Willi babies. And they were between 1 month and 6 months old. And after 1 week of administration, she looked at the sucking activity, and later on, at 1 year old and 2 years old, she performed some evaluation, some assessment of the behavior. So this is to show you the effect of oxytocin treatment in one baby after 1 week of treatment. So here you can see. Oh, well, it doesn't work. I'm sorry about that. I thought it could work. Well, I'm going just to explain to you what we should see. This is a test in which we put some, the babies are treated by oxytocin during 1 week. At the end of the 1 week, this is a video fluoroscopy. So there is a milk that is fluorescent, and you can see the uptake of the milk that is going in the mouth, and after is going to be swallowed. And you can see after treatment that there is a normalization that is represented here after oxytocin treatment of swallowing of the milk. Before the treatment, what we saw is that the milk stays in the mouth. So the baby has really a motor problem and is not able just to suck properly because the milk stays here and very rarely is going to be swallowed. So the baby has real motor problem to suck. And this problem is resolved after the administration of oxytocin during 1 week. In terms of social skills, what she showed is that it has been shown that different tests, well-being of social skills and the interaction between the mother and the pup are significantly positive. So it means that oxytocin improved the behavior of the pups and the interaction of, not the pup, the babies, I'm really sorry, of the babies with the mother. And so oxytocin treatment improves really social skills. So from mouse model to clinical treatment, what we can say is that in mouse model, in the MAGEL2 knockout deficient mice, we observe a deficit, of course, of oxytocin, but a deficit of the maturation of the oxytocin, what we call the oxytocin system. I mean just the oxytocin neurons with their connection in the brain and the release of the hormone. And so there is an alteration of sucking, of cognition, of social behavior. The administration of oxytocin in a critical window of time in the babies is sufficient just to have positive effect on sucking and on the behavior. And in the baby, the phase 1-2 clinical trial was really positive. And now, since 2022, there is a compassionate access authorization, meaning that babies can be treated with oxytocin. And today, around 100 babies in France have been treated with oxytocin, and apparently there are really positive effects. So to conclude, I would say that oxytocin is one hormone that is produced by the brain, and that through environmental cues is going just to modulate the development of the brain and to allow a normal construction of the brain. It's not the only one, and there are many, many other molecules, of course, that play this role. But at least oxytocin plays one of this role. And importantly, what I would like to say to conclude is that it is known for many years, as I said, that oxytocin produced by the mother is necessary for uterine contraction, is necessary for lactation, is necessary for maternal behavior, And today we know that oxytocin produced by the baby from birth, and this is the novelty of our work and of result, is important for sucking, is important, I didn't say that, for at least the vocalization of the baby, to appeal the mother, is important in social interaction, social recognition, learning, memory, and is important later on for social, again, relation at adulthood, bonding, sexual behavior, and so on. So I would like just to conclude to acknowledge the different people in my team that is present here who worked on this subject, and our collaborators, Maïté Taubert in Toulouse, Michel Desarmenet Montpellier, Pauline Strasbourg, Biche Kini, Elisabeth Amok, and other people again. So thank you very much for your listening. So if you have questions, do you hear me?
Yeah, thank you so much, Dr. Muscatelli. And now questions are open for the audience. Otherwise, I have some that patients were collecting during these days, and they wanted to ask you. And some questions over here? No? Okay, yeah, there is one. Just a few seconds, and now then. Wait a second. The microphone is not open.
The interpreter apologizes, but there is no sound.
Second. There's a problem with the microphone or the translation. Is it working now?
Hola. Sí. Teniendo en cuenta la.
So taking into account the proportion that you said between the neurodevelopment and the difference between the kids in mice, till what age in humans would be effective the oxytocin administration? You said in the first stages of development, so till what age is useful to give oxytocin to humans?
Well, the question, could you just repeat the question, please?
Sí, solamente.
I would like to know till what age would be effective to give oxytocin to humans.
The question is the timing for starting oxytocin treatment from the very beginning, just in the birth till 1 month old, 2 months old, 5 years old. Which is the best time, the best window for treatment in a baby, in a newborn with oxytocin?
So, for instance, I mean, the authorization given in France to access to the treatment is given for a baby between birth and 6 months old.
6 months?
Okay. Well, I mean, I guess that it can be given later on. It has been done, I mean, in the first trial. But the authorization to access to the compassionate treatment is given between birth and 6 months old. But I mean, oxytocin can be given later on. It has been given at different ages, during infancy, during adolescence, at adulthood, and some studies are controversial. There are no negative, I would say, effect, but the positive effect depends definitely on the ages of treatment, on the dose of treatment, and different things like that. So things are not so clear after that. But at least for the treatment of babies in Prader-Willi syndrome, it seems working quite well if it's given at this age. But it has been given in the first trial later on, after 6 months old. and well.
Okay.
It's clear that there is, as I said, I wanted to show you that at least there is a clinical window of time during which oxytocin play a role just during the brain construction. It was my main message, and it's why, I mean, the action is different if you give it in this period or if you give it at adulthood when the connections are already established. Yeah, there is a plasticity of the brain, but it's different from the baby brain.
Okay, thank you. So I will ask you a couple of questions, some from the patients. The first one is oxytocin and carbetocin, pros and cons. You were talking about oxytocin, all the advantages that you have shown. It looks like, as you said, that there are no negative side effects. And what about carbetocin?
Carbetocin is considered an analog of oxytocin, okay, but it's a different molecule. So from my point of view, I mean, oxytocin is the molecule that is produced by the brain, that is really well tolerated, that has an action on oxytocin receptors, but also on different receptors, and the action on receptor. The action of oxytocin on oxytocin the receptor is different from the action of carbetocin on oxytocin receptors. So from my point of view, I mean, if you can use the natural compound, it's always better.
Okay, thank you so much. And the last one, it seems like you were showing some data that the lack of oxytocin generates a problem in sucking, and it looks like a cascade of consequences. First of all, it can happen that the baby, in this case the mouse model, has no energy, let's say, because it's not sucking milk, and it can correlate with this hypotony, and can also correlate with the lack of maturation of the digestive system and the intestine microbiota development, and it also, due to this new access microbiota central nervous system, can be a kind of a domino consequences that the lack of oxytocin, no energy, no milk, no gut maturation. What do you think about this?
Well, the lack of oxytocin for sucking is a problem of motor activity controlled by the brain. I think that now we have enough data to show that, and that's fine. In terms of microbiota, you have to know that oxytocin receptors are expressed in the gut. So it means that oxytocin via the milk, for instance, because there is oxytocin in the milk of the mother, okay? So it's possible, but it has not been shown yet, that oxytocin coming from the milk given by the mother is going to activate oxytocin receptors in the gut and just play a role in the gut and possibly in the microbiota, okay? Another study has been conducted a few years ago, and it was at adulthood, showing it was not linked to Schaaf-Yang Syndrome or Prader-Willi, but in autism, that in fact you can change, if you change the microbiota, you can play a role on the oxytocin system as well. So it means that I guess that there is a link between the microbiota and the oxytocin system, and we have data showing that definitely oxytocin can be in the gut. Oxytocin receptors are present in the gut, but it has not been clearly demonstrated. Okay, so it might be. I wouldn't say. Well, it might be linked to a lack of oxytocin produced by the baby, a lack of sucking preventing the ingestion of milk coming from the mother, so from oxytocin coming from the mother. So it can be a cascade or different events that are going just to give rise to the different symptoms, I would say.
Mm-hmm. Thanks.
But of course, I mean, in terms of relationship, for instance, a baby that is not able to suck properly is not going just to be close to the mother, to interact with the mother. At least it's not the same interaction. And we know that the mother-baby interaction via sucking is really important for the social relation between the mother and the baby, and later on with the baby and other people.
Mm-hmm. Thanks. And the very last patient is asking whether there are some, that there are some products feeding, like not to mix milk with vitamin C because they are antagonists. And some patients are asking whether, for the treatment with oxytocin, whether there is something that can improve the uptake of oxytocin, and some products, some aliments that can avoid or can interrupt the better uptake of oxytocin. I don't know whether I explained properly.
Yes, I understand the question. I don't know about that. What I know is that babies, human babies, in the case of Prader-Willi, are treated by the administration of intranasal oxytocin, because we think that there is an action of oxytocin in the brain, but we cannot exclude an action of oxytocin in periphery, meaning that there are many oxytocin receptors in periphery as well, and those peripheral sites can play a role, can trigger something in the brain. So it could be a direct effect on the brain and an indirect effect on different places in periphery. So when I say in periphery, I say maybe in the nose, maybe the different organs that are in contact as well with the brain. So this is yet not clear. So the way to administrate oxytocin intranasally in babies, it seems to work, okay, but it could be, as I said, because it's going in the brain, because there is, this barrier, the hematoencephalic barrier, so it means that many molecules cannot access to the brain, except in the babies, because this barrier is more, there is a plasticity of this barrier in the babies, but we also can have an action in periphery. Looking, at other molecules that could prevent the action of oxytocin, from my knowledge, I'll say I don't know. I don't know. So what is important is the period of the treatment, the way of administration. But it seems to work with intranasal administration. Maybe we're going to show in a few years that another way of administration could be better, but at least it works with this kind of administration. Because you have an effect possibly in the brain, but you have a peripheral effect as well.
Okay, thank you so much. Some other questions for the audience? No? Okay, so with this we finish, and we thank you. We are very, very grateful for having you here, and it's a pity we cannot see face to face. All the best.
Yes, I'm sorry about that.
No,
I hope next time
next time we will meet for sure. Thank you so much for this important information you sent us for the patients and for the scientists. Thank you. Merci.
Merci.